We're super excited to present this topic. It is Advanced Scleral Lens Evaluation and Empirical Fitting. And I'm here with a very, very dear friend of mine, Dr. Tom Arnold. And before we get started, Tom, would you mind giving the listeners just a brief kind of bio of who you are and kind of maybe how you got involved in this type of technology to begin with?
Sure. Well, the long short story is that I've been in practice since 1984. I opened my own practice in 1992. And so I'm a private practitioner just outside of Houston, Texas, in Sugar Land. And we have two other doctors with us. And I just started out as general optometry, selling glasses and contacts and just doing like any other private optometrist, but I always liked contacts. I always had a grounding in gas permeables and multifocals and so forth. So I'm just booking along. I knew about sclerals, when they started becoming available, in the early 2000s and so, but I didn't feel like I had that niche. And I was encouraged by a corneal specialist that I did a lot of work with to start fitting. And rather reluctantly, I kind of drugged my feet a while, but I was encouraged, and I actually went to my first meeting to be introduced to sclerals was with a good mentor of yours, Stephanie, Ed Bennett, and Greg Denier. And actually, Greg Denier is the first one that put a scleral lens on me, and I was, very amazed how comfortable they were. And my next patient, who was a good candidate, I bought a fitting set and put it on. And, once you start fitting these wonderful, wonderful lenses and see the joy that they bring to patients and the impact on their lives, you're hooked. So I've been fitting sclerals now for about 8 years, out of a 34-year, a 36-year career.
That's awesome. Thanks, Tom. And you guys can see how well versed Tom is in scleral lens fitting, and he's got such cool photos and case reports on his Facebook and Instagram pages, and he also is an administrator of the Scleral Lens Practitioner Facebook group, which is really cool, where we get to share a lot of cool case reports and get some troubleshooting tips. So thanks, Tom, for being here. And just a quick brief bio on myself. I also was kind of like Tom in the beginning when I started practicing about 10 years ago. I was basically joined up with a private practice, doing everything: glasses, contacts, red eyes, diabetic exams, post-ops, all that kind of stuff. But I had completed a residency, so I really wanted to integrate scleral lens fitting into it. And so I started fitting scleral lenses, during school and then during my residency, which is just kind of when they started to get popular again. And then, then I just kind of incorporated that into private practice. And now I have a new practice in Las Vegas, and that's all I do. So I only do specialty contact lenses at this practice now. And I think all of you viewers are going to learn all there is to know, or at least we're going to try to educate you as much as possible on kind of how scleral lens evaluation has really evolved over time. So thank you guys all for being here tonight. We also want to say thank you to Visionary Optics. This event is supported with an unrestricted educational grant from them. And both Dr. Arnold and I are very lucky to work with lots of different companies. And so before we kind of jump into just diving right into the scleral profilometry or topography, Dr. Arnold and we kind of talked about some of the things that kind of evolved over time and some of the things that happened with us in our own careers. And something that I remember, I believe it was Christine Sint, amazing doctor. And at one of the meetings, she said something in one, I think it was at GSLS, and she said, remember that with scleral lenses, you're taking the cornea out of the equation. You're fitting the sclera itself. You're not really fitting the cornea. So that like really resonated with me, and I just thought, I think I've been taking these topographies of the cornea a little bit too literal in the sense of all of my fitting choices were kind of based off of that initial topography. And then as you start fitting these things more, you realize, you know what? the scleral shape and the scleral topography and whatever the sclera is doing is incredibly important to how the end result is going to be. So Dr. Arnold, I wanted to ask you, would you find that 8 years ago when you started fitting these, that the shapes have changed or the fitting sets have changed, or what has your kind of been your experience like as this has evolved?
Well, just like you, Stephanie, the original Scleral lenses, the big 21, 23 millimeter lenses that some of our early developers were using, they had spherical haptics because they said they weren't sealed lenses. They expected some tear exchange. One, because the materials were not very permeable, and two, they didn't have the technology to map the sclera, so they just made something big enough to stick. And as the lenses got smaller, the techniques, the manufacturing techniques got more sophisticated, and the lenses became smaller. Then you have this very toric sclera, come into play. And my first couple of fitting sets had spherical haptics, and I remember my little anecdote was with another mentor and icon for us is Lynette Johns, and I got to know Lynette pretty well over the years, and she's a very good friend. And I remember attending one of her early lectures, and she was saying something like 95% of all my lenses now have a toric haptic, and I had just used one or two lenses at that time, and I don't think I had any of them toric. And I went, wow, that's incredible. I never thought of that, or I didn't think I saw the need. But then when the realization came away that with a toric haptic, it really does fit better. And so, yeah, it was, everything evolves. And so I was taken aback by that, but soon saw the light.
Yeah, and it's interesting that the companies, like you said, Tom, they started off with just spherical back surfaces because there wasn't a lot of information or research.
And to your point too, Stephanie, the early sets, because people understood topography and these were rigid lenses, some of the early fitting sets, the lenses were described in K readings, even though they're scleral lenses. They would say, well, fit half a diopter steeper than the flat K. So they were still referencing the cornea, even though we're fitting sclerals. I'm sure you have a couple of fit sets like that as well.
Oh yeah, it's really interesting where things how things have progressed. So just like Tom said, most of the fitting sets like 10 years ago had just spherical back surfaces, and we didn't have a ton of information about scleral shape really at all. And the other thing is, even if you could have deduced that, putting a lens on and saying, this doesn't look like it's fitting the eye properly, a lot of the fitting sets back then just didn't even have the option to add toricity on the back surface, which is totally different from now. I just wanted to go through quickly just a study that Dr. Arnold and we both reference this a lot, and a lot of our good friends that were involved. But this really was a eye-opener, I think, for a lot of people in the industry that were fitting scleral lenses to any extent. So basically, at Pacific University, they took 96 eyes and they used a Visante OCT to take a look basically at how things were angled on where the limbus was, and then all the way out to like a 20 millimeter cord length. So if you all are slightly familiar with the OCT, they measured from basically the limbus down to a 15 millimeter cord length, and then they repeated another scan where they're going from 15 millimeter cord length to 20 millimeter to just kind of understand what's going on with the shape of the sclera. So as you can see here, this is kind of the first scan on one of their eyeballs. So going from basically the limbus, to a 15 millimeter cord length, and you can see the different degrees, and they're quite similar as far as, 37.7, 37, or 38, they're all kind of similar, not all the same. So certainly not spherical, but not a huge varying degrees. But then as we get larger or you know, out into this 15 to 20 millimeter cord, you're really starting to notice a lot of different shapes going on. So you've got this huge variability the further you get through the limbus. This is kind of that information put together. So if you were looking at an eyeball straight on, like if you're looking through the slit lamp and you're looking at this blue thing, pretending it's the cornea, you can see that as you kind of get further away from the limbus, the sclera does in fact become more toric. And then here's just another bar graph, just to kind of show you that when you're in that 10 to 15 millimeters, it's not as variable as when you get to these larger cord lengths. So I think that was really, really important to the industry. This type of research was showing that, you know what, as we get further away from the limbus, we really should start to look at adding in some toricity to the back surface. And I remember, Tom, the same thing as you, as when I read that there was a study that Dr. Greg Denaire posted. I think it was in Contact Lens Spectrum in the beginning, but he talked about how a majority of his fits had like a back surface toricity, and he only had like 20% that had a spherical toricity, and then the rest of the 80% or something was toric in some way. And I was like, you know what, mine's completely backwards. I had 80% in spherical back surface, and then I had like 20% that were in toric, and I'm like, there's something wrong with this picture. So I agree with you, Tom. I think that it's something that we all kind of discovered. And I'd love if you kind of talked to this slide. I think this is so important.
Oh, good.
This information.
Yeah, really. The fact is, the spiral of Talot, which of course we all remember from ocular anatomy, is just a recognition that the extraocular muscles insert at different distances from the limbus. And so, that's, we've understood that for some time. But the unique thing about the slides that you just presented, Stephanie, from Pat Caroline or Andy Kojima and so forth, that Pacific study, was that not only is the distance different out to the extraocular muscles, but the elevation of these areas is different, and the angles are very straight or very tangent. Looking, if you have the time to look back at those slides, you'll see that once they get off the cornea and get beyond the limbus, those angles are extremely straight. And so we're used to thinking of curved corneas, and we're used to thinking of the globe, and it's like a big basketball. But actually, once you get onto the sclera proper from the limbus, things become very straight. And so you'll see this in some of the newer designs of the scleral lenses, that you have curved base curves and mid-periphery curves, limbal curves, but then when you get on these haptics, some of which become very, very straight and flat. And so I think that, and also not only is the angle different, but the elevation of these areas is much different.
Yeah.
Profilometry helps illustrate that.
That's something that I don't think we really knew, and probably a lot of our listeners are just learning this information for the first time. So thanks for explaining that. That was excellent. So here's another study that Tom actually had in one of his most recent presentations. But basically, in one of these journals and a lot of these different articles, it shows that only 6% of patients that wear sclerals actually had a spherical sclera, and only 29% exhibited regular scleral toricity. So Tom, when you look at this study, are you thinking in your head, if only 29% have regular scleral toricity, that means that the majority of patients in my chair have irregular scleral toricity? Is that what you are seeing now? That you are...
Absolutely. Okay. And that number resonates with me, Stephanie. I bet you I only have about 5% of my fits have a spherical haptic. I mean, so I'm Lynette Johns was way ahead of me 8 years ago, so it's probably 95% toric, and it's only very small lenses like 14.6, 14.9 that would have a spherical haptic, as your illustration showed. So yeah,
Yeah.
this really hit home. And the other thing is we've seen a trend towards quadrant specific lenses, and of course you and I are about to talk about individually designed, empirically designed lenses that addresses this irregularity that, 60% of our patients
Yep.
need that kind of lens.
Yeah, it's incredible. So I wanted to just kind of go over with the viewers on what profilometry actually is, because I remember hearing that term and thinking, what the heck is that? That's not something I think I learned in optometry school. But basically it's a way to get this topographical data from some sort of surface. And there's different machines out there and instruments that Dr. Arnold and I are going to talk about. But and most of them are using some sort of a light source to do this. And currently, as of today, there's 3 instruments on the market that are able to do this. One is the SMAP 3D. I have a lot of experience with that device. Tom Arnold has the Eaglet ESP and the Pentacam CSP in his office. So we're going to kind of talk about these different instruments, kind of the differences, pros and cons, and kind of who would be a good candidate. So this is just kind of some examples of the information that we would be seeing if we were taking the image from the Eaglet or the SMAP or the CSP. And this kind of is showing us what kind of information the data has kind of collected and put onto like a color point. And Tom, are you using this information like right off the bat? Are you taking an image and then you look at it and say, well, according to this, we really have got to consider a very high amount of toricity, or does that kind of guide your prescribing habits or recommendations to patients?
It really does. It really serves 2 purposes, Stephanie. The one you just articulated, it gives me a lot more information about how complex the case is. What kind of lens do I think, what kind of features of a lens are needed to fit this particular patient. But I think, technology also has another aspect or benefit in patient care, and that is explain the patient the nature of their problem. And over the years, as we've added various instruments to our practice, the patients go, there's a wow factor that, oh, I didn't understand. No one's ever explained this. I've never seen this before. So it really helps kind of justify, that this is going to take a while. It is more expensive, but I'm the expert. You're in the right place to do this. So I think it helps, explain, well, why is this so difficult? And so there's a little wow factor in it as well.
That's awesome. I love the way that you explain this to patients. And so just like Tom alluded to before, this type of technology has really given us the ability to create these incredibly custom, unique lenses. So you can see with just by looking at this scleral lens, that is not a typical scleral lens that you see out of your fitting set. This is somebody that's got a very interesting, complex eyeball. And just like Tom said, sometimes showing them what's going on with their eye and what the issues might be and why maybe they haven't had success with other things in the past, it really can kind of help the patient understand their own condition. I think that is so important. And then just a few slides of patients that would be good candidates. And of course, Tom, I want your opinion on all these. But first patient that comes to mind for something a little bit more custom or that would need some sort of profilometry or would benefit is somebody where you have this, you put on the lens in your fitting set and you think, well, inferiorly, it's looking pretty good. But at the 3 and 9, there's some real real issues. Is this something, Tom, that you maybe would have seen a lot more maybe 8 years ago?
Oh, certainly. And be frustrated trying to fix it, you know, and yeah, exactly. Yeah, because these
Awesome.
elevations are different. Those lenses are landing at different places. We've all experienced that lenses tend to decenter down and out. And
Yep.
because typically the nasal aspect of the eye is higher, it's flatter. If you know, go back, look at the slides that we saw earlier, the angle is less and the elevation is actually higher. So in a typical, with the rule, of course, we just talked about how there's nothing really typical. These lenses will decenter. And so you'll see a lot of clearance below, and we'll talk about the shape of the limbus in a minute, but it's also the elevation differences. So yeah, it's very, you look at this and go, yeah, I need another answer.
Absolutely. Here's another just patient that comes to mind. And these are a lot of patients that get referred to me, and I'm sure they get referred to you all the time, Tom, where the practitioner has kind of done as much as they can with their traditional scleral lens designs, and they don't really have the ability to fix maybe a pinguecula that's getting smushed, or a pterygium, or just some sort of irregular scleral shape. So when I think who is a great candidate for scleral profilometry or some of these more custom lenses, if I see any sort of pinguecula, I immediately point that out to them when I'm going through some of these images with them and showing them, you've got this area of tissue that's more elevated like a speed bump. So if we don't do something more custom, it's definitely going to be more challenging to kind of fit this area properly. And we may never be able to get to the end result like we would with the custom lens if we just keep going down this path. And I know both of us have done that, where we've just kept trying to make modifications to some of the standard lenses, and it's just not working no matter how many times we do it. And then at the end of the day, the patient gets frustrated and they're coming back a million times, and then you're frustrated and the consultants from the lab are probably frustrated. So all around it can provide a better experience.
That's true. It's better to identify it early and tell them rather than have them come back and you not. But this is a great slide, Stephanie, and going through this presentation, I wanted to point out this is a great slide, and not only because it shows that it's riding up on the pinguecula, as your arrow illustrates, but notice how above and below the pinguecula there, you see the shadow. You see the big shadow, particularly from like 2 to 3 o'clock. And that just shows that pinguecula is lifting that lens off. So they're going to feel it. It's going to rub. They probably get some bubbles underneath it. So it's not just impinging on the bump and, inducing some redness, but it's just not fitting well. And so, yeah, it's a great picture, great photograph.
And here's actually your picture, Tom, not a patient that you fit to initially. This is somebody that probably came to you looking for help, but can you tell us a little bit about this patient? I think you ended up fitting them into like an eye print from your
That's absolutely right. Yeah, Stephanie and I shared these slides, and I said, well, I'm going to show you, I'm going to give you slides. I said, I did not fit this patient. This is my patient, but I didn't fit it. Very interesting lady. This is a young physician, actually, who was had LASIK in India, and she probably had early keratoconus that was not detected. And so she's very, very ectatic, just cornea was crazy, and was fit elsewhere. And it's, as you see, it's too small, it's too tight. And she actually got some chalasis, conjunctival chalasis, or that's not the right word, but calcification, whatever. It got really hard and brittle. And yes, we did. That's exactly what we did. We did an eye print on her to get over this, much larger. It improved dramatically. Like in 6 weeks, it was white and clear. But of course, the architecture changed. So we actually did another mold, and she's quite happy. So yeah.
No, that's excellent.
Oh yeah, that's a good example of it just gets congested. You're just digging into there and pushing it up. It's exposed and it just dries out. So it's always red. It's pretty nasty, but she did real well in a custom lens. Yeah.
That's awesome. So basically, if you do scleral profilometry or topography on patients in your practice, there's lots and lots of benefits. So just like Tom alluded to, it gives you excellent information about the scleral shape. And then you can have that conversation with your patient and say, hey, this is what's going on with your eyeball, and that is why I'm recommending this lens type. Because these lenses are so custom and they're made very, very well, it does save time. So not only the patient and the doctor time, but it's really everybody's time that's involved in this whole process. So I like to tell people that when my first scleral lens patient during my residency took me 20 different lenses and 7 months of both of our time. I guess granted, you know, I was a resident, so I didn't really know what I was doing in the beginning. So that was to be expected. But imagine now, you know, if somebody came in and they were trying to get fit with a lens and they couldn't, they had to keep coming back in a million times. I mean, people just don't have time for that anymore. I'm including myself. I mean, I want to go to whatever doctor I need to go to, and whatever is going to get me to the end result the fastest. I think that is really important. And Tom, I'm really curious on, is this something that you explain to patients before you kind of decide on a lens to use? Or is the patient the one that's kind of involved in the decision making, or are you just kind of making a recommendation or two based off of everything you see?
You know, when patients come to us, they know they have issues and they know they're difficult. Either you know, they have issues that they can't see, or maybe they've been fit elsewhere and they see the benefit of a scleral lens, but it just doesn't fit right. And so they're open to, they want to be fixed and they want to get back to work or school. And as you well know, Stephanie, you know, having a specialty practice, you know, that's totally focused on this. And we're a general practice, but as we built our practice, we have lots of referrals. And as you well know, people may come from hundreds of miles just for this, for your service. So I think we owe it to them to explain that we want to get to the end point, as you said, as quickly as possible to get them seeing well and getting comfortable. And you know, we may have good, better, and best, but you know, we're the doctors and we say this is what you need, and that goes a long way. I think lots of times optometrists maybe are more timid about discussing fees, or you know, we'll do something easy. If that doesn't work out, we'll take the next step, and after that. But I've gotten more bold and just say, look, this is what you need to do. And I don't want to oversell people. I want to do what's appropriate for them. But it's up to us they're coming to us for our advice. And I think we owe it to them to give them the best option we have.
I love that, Tom. And that just goes to speak to what kind of doctor you are. As you know, as many doctors and patients know, you're just somebody that is very honest and trustworthy, and somebody that's not going to just sell somebody something because they don't need it. You're actually telling them, hey, we want to do what's best for you. We want to get you to the end result the fastest, especially if they're traveling, you know, hundreds of miles. That's I think so important. And thank you for sharing that. I think a lot of the listeners really are going to appreciate that token of advice. Something that we haven't really discussed is empirical ordering. So something that is really exciting about this profilometry data, so if you end up getting one of these instruments in your office, is that you're able to capture the images, and the laboratory is able to actually look at the image on their end, and then they can create a lens that is really, really custom to that patient's eye. So you're not fiddling around with multiple trial lenses in office trying to figure out what the best fit is. And would you say, Tom, that this has decreased the amount of chair time with your patients?
Definitely. In this era of COVID and cleanliness and all this, patients appreciate that. You know, they don't want 2 or 3 lenses that maybe have been on someone else's eye, you know, previously. So they are concerned about that. And we, even if you use a diagnostic lens that your profilometer may recommend, you can be pretty confident. My experience has been if I am doing a diagnostic lens, that lens that is recommended will fit. Now, I may modify it, I may want to tweak it, but I'm not putting on 3 lenses, and I'm not putting on brand A and it doesn't work, and I'm putting on brand B and that doesn't work. Now I'm on to brand C. The lens that I select, I know is going to work, and the diagnostic lens often is. So if I can just put one diagnostic lens on, that's good. But Stephanie, we've done empirical fitting for corneal lenses for years. I mean, I don't do diagnostic fitting of corneal lenses at all. I take it from the topography, and the lab makes me a lens. So I think that's where we are. We're almost there. I think there's some more work to do, but I think in the next 12 to 20, 18 months, we probably won't be fitting many diagnostic lenses at all.
Yeah, and that's so wonderful, with this time in our careers and the culture with everything, like you said, just trying things on, and somebody else has had it on, and all this stuff with the fear with everything. And I don't think that's going away anytime soon. It just gives the patient a little bit more confidence as well, that you're not using all these lenses that were on a million people's eyes just, a few hours ago.
Well,
So
and the other thing too about the corneal lenses is that, if you take a diagnostic corneal lens, say, and it's is way off. Let's say, you need a bitoric, say a 4 diopters of corneal cylinder. You put that diagnostic lens on just for whatever reason, it's not going to fit. They're not going to be comfortable, and that's their experience. That's their expectation. So you want that scleral lens, which sclerals are by definition more comfortable, but you want it close. So if you have an empirically fitted lens designed for off their profilometry, the wow factor is really, really good. Some manufacturers will make you a lens and make it plano even, and
right.
you'll put it on, you'll explain to the person, that this is still a template, but it fits. And now we're going to give you the proper power. And so then you have one visit, not 3 or 4.
Yep.
So
I know it has really changed the whole culture of scleral lens fitting. All right, Tom, I'll let you take it away with your case reports here.
Okay, great. Well, this is a very typical patient that we've talked, similar to the cases we talked about. Here's someone who has keratoconus and all the associated signs with it. You can see he has a lot of astigmatism, oblique, 20/40 in glasses, and he's worn sclerals before and sees the benefit in the vision, but he wasn't that comfortable. This gentleman actually came from a couple of 100 miles away. We always brag about how big Texas is. So he was referred to me and driving in. So I went with an empirical lens, a ScanFit Pro lens, right off the profilometry scan. And so for this one, I was using an eaglet device, which I work with Eaglet. And you can see that it is using fluorophotometry. So we do use some fluorescein. Gets us out to 20 millimeters with straight ahead gaze. So we're not engaging, any muscles. These are bisphere elevation maps. And again, talks to the slide you were talking about earlier, Stephanie. If you look at the right eye, it's pretty typical with the rule scleral toricity. So he's steep vertically and flatter horizontally. But look at the left eye. Look how asymmetrical that is. And this is an example of what Dr. Denier and Dr. Sanders and Jason Judlicka found in their study, is that yes, he's steeper vertically than he is horizontally in terms of the veil, but look at the asymmetry in the steep meridian. There's like 300 microns difference. So even a toric haptic is not going to work in this case. Yeah. So this is we imported this data. We imported this right into the ScanFit Pro software, which talks to this instrument as well as the Pentacam. So we're pulling the data right in, so there's no transcription on our end. And yeah, this is there's several steps that we go through. In the interest of time, I'm not doing every step, but the software defines the limbus. There's a picture of the eye. That's the real eye. The software is saying this is where it thinks the limbus is. You can click on these points. You're in control here. You can click on the points, move them around. Yeah, that's fine. Yeah. And there's several steps. You get to this step, and this is designing the back surface of the lens. So this is how the lens is going to fit. The little golden area on the lower left there is a raised area for a pinguecula. They call that a bump. You can make it a multifocal, and if you look real carefully, you can see a little dotted blue line coming out of the apex, and that's the optical center of the lens, and you can move that around. And so, you can look at the shape. This is scan data. It looks like molds, but they're not impressions like eye print. This is scan data from the eaglet. You can see it's very interesting. There's a lot of data now, Stephanie, as you know, that the limbus is oval. It's mostly oval. It's mostly wider horizontally and shorter vertically. Also, it's higher up vertically than horizontally. It can be against the rule, but typically they're like this. And on the lower right, you can see how that bump or like microvault is made into the lens. So this is all, didn't touch it. This is all a scan. And so this is what the lens would look like. You can see that the optical zone is indeed oval. And this is not a huge lens. We're not talking about a 20 millimeter lens. I think this was, I forget what it is. I think it's 16.5, 16.8, which is a very typical lens. But no hands were made. 16.5, here we go. So this is final prescription. You can see he's got some astigmatism in the left eye. And you look at the optical zone, you see how different it is. It's more than a millimeter different in the right eye and not quite that in the left. So yeah, pretty neat. And this is what it looks like.
Wow.
So
that's
yeah.
Beautiful. And here's the left eye.
And here's the left eye, yeah, right and left eye. And they're comfortable. Wow. He puts them on and goes, oh, man, this is it. This is what it should be. Yeah, that's how you build your practice.
Wow, Tom, that's incredible. Thanks for explaining it. It was so easy to understand how, thanks for your explanation on kind of how you got the scan and then what the little points are representing. And it is fascinating knowing how the cornea, the lenses are no longer round. We're making these oval lenses. It's incredible now that we have so much more data about the cornea and the limbus and the sclera, how the eyeball is really not round at all.
Yeah. And it's not just the limbus and the optical zone. We're making lenses that are oval in shape.
Yes.
The whole lens. Yeah.
Fascinating.
So again, this is another illustration. This is the Pentacam, and it uses a Scheimpflug camera. As you know, it's not fluorophotometry. It takes a central image, and then the instrument actually moves up, down, left, right to get it. It goes out to about 18. And if you look on the left there, the little blue bars, that's an illustration, and you see the angles there. So the camera spins around, takes 2 seconds, literally 2 seconds, and this is their scan. And so we call it fitting by the numbers, and for practitioners who are really just getting their feet wet, the first thing you look at to me is what is the horizontal visible iris diameter. Now we know the vertical is probably going to be a little bit different, but this is how you pick your first lens. In this instrument, it's called the horizontal white to white, and we have a measurement there. So 11.6 is a very average width. And so in this particular fitting set that I decided to use, I went with a 15.6. And so this is the data we're getting off the Pentacam. And what I really want to emphasize here is that You need to know for any given overall diameter of the lens you're using, it doesn't land on the outer edge. You know, a lens doesn't land on the extreme edge. It lands somewhere inside of that. And all the manufacturers, if you ask them, will share that information with you. My core diameter, where the lens is going to touch down, is where you need to take your sagittal depth measurement from. And so I know from this manufacturer, a 15/6 lens actually lands at 13/6. So the sagittal depth that I need to clear, well, is 3355. Of course, I want to build in my clearance of the lens. I don't want it sitting on the cornea. So my fudge factor is 300. So I need a lens on the eye that has a sagittal depth of 3655. That's the information I'm getting off this. And so I go to a calculator. A lot of labs that you use now have online calculators. So whichever labs you like to use, ask them about that. So it's a normal HVID, it's a normal cornea. So kind of an average lens out of this fitting set would have a SAG of 4600. And so we put that in and we calculate, well, what is the sagittal depth of this lens on the eye if I pick a 4600? And as it goes down, it spits out the parameters and it says, well, the primary functional sagittal depth, and we're going to talk about where we get that term, is 3820. So I know if I put that lens on the eye, I'm going to be 165 microns too high. I want 300. That means this is going to be 465. So I don't want that. So then I go back to the calculator. So I say, okay, I want to drop it 150, which is what I do. So this is the lens I'm going to put on the eye. This is the first lens. Then I'm going to do a little over refraction. Yeah, there you go. I put in my over refraction and then I calculate again, and it comes out to 3670. So I'm within 5 microns. So this, in this case, this is my diagnostic lens, and this is what I'll order. Yeah. So another case, very similar, moderate Keroconus. This gentleman comes from about 120 miles away. He was only diagnosed, as you see, when he's about 34, which, Stephanie, you know, keratoconus starts very early, you know, certainly in adolescence. And he was referred by a friend of mine in Beaumont, Texas, which is, like I said, about 120 miles away. And his chief complaint was, I haven't seen well in years. The guy just doesn't see. So I fit him actually several years ago. Let's go back to the topography like we talked about. He's got a cone. I want to know the nature of the cone. And when I first saw this, Stephanie, I went, man, you know, that left eye looks so much worse than the right. It's got this big cone. It's low, you know, low and outside, you know, like my friend Bill Potter would say. You look at the right eye and you go, that's a central cone. That ought to be easy to fit, but look at the difference in the vision. And if we go to the next slide, and this is where, this is not profilometry, this is Scheimpflug. It shows the front elevation and the rear elevation, because we all know that for most keratoconus, it starts in the rear and moves forward. So you can see here his Kmax is much different in the right eye. He's a lot thinner, the elevation's a lot worse. So indeed, the right eye is the more difficult eye in terms of vision. Something again, you know, myself coming from a rigid lens background, you know, starting in the 80s, I mean, we're used to topography of axial topography or tangential topography, where you know, where the highest point, where the area of most curvature would be red, right? And the area of least curvature would be blue. But we all know that in elevation maps, that's the opposite. So it's important to get your mind around, these are corneal scans, of course, but the same thing is what we see on the sclera. And so the red point is the highest point, okay? And then the highest and flattest in this case, and the blue surrounding it is the steep meridian. So your task here in fitting this is to get over that high point, but not have excessive clearance, you know, as you get off that. And so, so that's one point. Point two is, how well can we get these people to see? It's much easier. You can expect better visual acuity when the maximum elevation in the front and the rear line up as they do in these cases. And in this case, not so much, right? So there's your front elevation. Look how ectatic and distorted the rear is. So again, these are elevation maps, and we're looking at the cornea, and this is the Scheimpflug of that same eye. So I fit this guy in a custom lens, and he won a shooting clay tournament.
Oh, that's cool.
He won a shooting clay tournament. But anyway, going back to our friend from Beaumont, so I fit him early last year, in Scleral lenses, and he really liked them, but the left lens started bothering him. You can see that he had a cylinder in his prescription. I also had 200 microns of toricity, which I thought would be good, but you can see from my little drawings that the left lens was rotating and dropping and abrading his cornea.
Wow.
So that was not good. And one thing, our good friend Karen Carrasquillo has mentioned this a bunch of times. She said, no follow-up visit is complete unless you take the lens off and stain it. So, it's a very good point. And so when I do this, you can see his abrasion. You can see how it's kind of digging in there. And so my strategy, why again, going back to, no, that's fine. That's fine. Going back to what we keep talking about, this is Greg and Dr. Sanders and Dr. Denier and Jesse. Like these are their findings, Stephanie, that you articulated earlier.
Yeah, this is such important information, and it wasn't well known, and it's just so amazing. And I just love seeing all the new data come out, because it really shows, even what we know now. I'm so interested in seeing what's it going to be like when we have 5 years of data with these different shapes of people's scleras, and people that have regular astigmatism versus irregular, and different different conditions. Does that affect the scleral toricity pattern? And I think we're just going to be able to get so much more information now that we have this incredible technology.
Yeah, this paper is just, as you can see, November 2017. It's not 3 years old.
Yeah,
it's a great paper. As you said, I have it in almost all my lectures.
yeah,
because it's so groundbreaking. But going back to what we talked about, primary functional sagittal depth, that is the actual depth at the core diameter that you're trying to fit, and that's an important. That is the clearance of the lens, and it comes from this very good paper, which is a little over a year old, by some good friends of ours, Stephanie, who all these nice folks, good folks, and we're trying to simplify the terms we use, because every manufacturer, God love them, it has different names for everything, and it's extremely confusing. And there's an attempt by these fine researchers and doctors, practitioners, and others to let's all use the same. Let's have Esperanto for scleral lenses.
yes. I think that would be wonderful. I know that the Scleral Lens Society has done such a great job and in helping this come to life. And yeah, it's exciting to see where this ends up going in the next few years too. And I'm just going to kind of move on here.
Yeah,
we're running out of time here. So I'm just going to end with this case report, and then we'll kind of conclude here. So I had a 79-year-old female, and she was referred to me by her ophthalmologist here in Las Vegas. She does have a history of RK scarring in both eyes, and she had epithelial ingrowth repair in the right eye about 3 months before she came to see me. And she does have significant cataracts. Her symptoms were poor vision, double vision, fluctuating vision, and she just basically says, I can't see anything. Her vision in her right eye was 2400, and she said she saw double. And then in her left eye, she saw 2070, also seeing double. Take a look at her topography. There's definitely some flattening and irregularity. You can tell that she has had RK. Not too bad as far as some of the crazy topographies that Tom and I see in our regular basis. So I thought, okay, well, the topography is not looking that bad. So, you know, there's definitely a chance that there could be improvement. And she's got some RK scars, kind of hard to see in this photo, but then you can also see she's got some interrupted sutures inferiorly. And then the biggest challenge was she's got basically 3+ NS cataracts. So I thought, oh geez, she's got, you know, RK, she's got this irregular astigmatism, she's got some surgical repair, and she's got some pretty significant cataracts. So I didn't even know if this would even work, but the surgeon is the one that said, I don't think she needs to be going through cataract surgery right now. Let's just see what she can get in a scleral lens. So I thought, well, I mean, I guess I'll try, but I was very clear with the patient that this may not work at all. But first, you know, let's just try something and kind of see what happens. So we performed an S-map on her, very similar to the eaglet that Tom talked about, where you have to use fluorescein. So you use fluorescein, and then you basically have the patient look straight ahead, up and down, and then that captures the profilometry for that patient's eye and then stitches the images together. So amazingly, with the diagnostic lens that was recommended, and with an over-refraction, she does have some astigmatism going on there, but she was able to see 20/30 in the right eye. So going from 2400 to 20/30, especially with that dense cataract, I was pretty amazed. Same thing with the left eye. She does have a lot of astigmatism going on, also 20/30, and she was happy. So she said, this is the best I've seen in years. Like, let's just go for it. So I thought, well, might as well try. So decided, let's do it. She's got a lot of cylinder going on. And because I wanted the cylinder correction to be very stable, I recommended going with a custom scleral lens, which in this case is called the Latitude. So she decided to go for that in each eye. Here's her dispense. You can see that the lens is fitting quite well. So even though she's got some scleral toricity, not a big issue. 238 microns of clearance, I'm happy with that. Lens dispense for the left eye, beautiful fit, that looks great. And again, she's got adequate amount of central clearance right off the bat. And then she sees 20/25 with the lens on and 20/20 in the left eye. So this was like this case where I was like, I don't even know if this is going to help at all, but let's just try it just to see. And I don't think that I could have gotten this good of vision if I would have done a regular scleral lens, and that's just because of how much extra toricity on the front surface we had to add. And as you know, Tom, it has to be so stable for that vision to lock into place, which is where some of these custom scleral lenses really shine.
Stable and centered, that you centered it.
Exactly. So that's where, you know, when I see a patient now that has some toricity on the front, so that if they've got some internal astigmatism going on, I almost always tell them, listen, we've got to go with something more custom because I need that lens to sit exactly where we want it to sit. I can't have this thing being rotated because your vision's going to be bad and then, you know, you're going to be unhappy. She did great 2-week follow-up, no issues. We saw her for a 3-month, about a month back. She's still doing amazing. So there's a couple questions. I just wanted to answer a couple and then I wanted to turn it over. But if you guys do have questions, Tom and I we're such advocates for this type of information. Happy to share. This webinar will be recorded and posted, so I'll make sure to email all of you guys in case you want to look at it again. I mean, Tom had some amazing slides if you wanted to go through step by step how he was talking, and that was incredible. And then we both have social media things that you can follow, and definitely if you haven't followed Tom's, make sure you do, because his photos are just absolutely amazing.
Thank you.
And then just one question, Tom. I wanted to kind of ask a question that came in earlier in this in the conversation, which for you is, would profilometry take the place of eye print in Tom's case. I think it was one of the first cases that we had presented.
No, it doesn't take the place. Eye print still would be your definition. I mean, that's going to be the most accurate. In fact, those 3 profilometers were standardized against molding, eye print molds. So for a very, very ectatic eye, a really torn up eye print still would be the best thing. But this profilometry is those in-between patients, just like kind of what you just illustrated, Stephanie. More difficult, challenging, but not crazy.
Yeah, excellent. And then just one more, what is the average number of lenses before the final with the profilometry versus without it? And I have actually, one of our good friends, Dr. John Gellies, actually did an audit of himself. And he's got a ton of information on this exact research within his own clinic. And I believe it was something like, without using profilometry, it's like 2.7 lenses per patient. And then with, it was like 1.2 or something like that. Tom, do you think that is kind of reflective of what you're seeing?
Yeah, I think we all know John, and those are the numbers that I recall as well. And that he does crazy eyes, Stephanie, as you do. He's in a specialty corneal practice, and he does hard stuff one after the other. And for him to have that kind of a result, with the person of his skill, really speaks to the technology really improving. Yeah. So yeah, that's great. If it helps John, it'll help everybody.
Definitely.
Yeah.
Well, thanks, Tom, for spending your evening with me and our listeners. This formally concludes the CE portion of the event. And so now